today, mostly I'll be talking, going through pretty much all of the genetic screening options that we offer. A little bit more of a focus on the non-invasive prenatal testing because that's the biggest thing that's been changing a lot recently. So I'll be talking over all of those things, a little bit about genetic counseling in general, and then happy to answer any questions also. So we do know that there are many screening options available to people these days. They continue to change. There continue to be more things offered, and it can all be very overwhelming knowing what we need to offer to a patient. And that's one of the big things with genetic counseling is that we're there really just to talk to people about all of those options. We are never trying to make a patient choose any particular testing or force them to test, but we want to make sure they have all the information that they need. So as far as screening tests go, there are quite a few different types of screening. As far as chromosome abnormalities go, we can screen for those with both ultrasound as well as maternal serum testing. So the first ultrasound that we like to do to give people some information during the first trimester of their pregnancy is the NT ultrasound. And by doing that test, we can give them information about chromosome abnormalities as well as birth defects. And that ultrasound alone, if we have a normal NT result, we can greatly reduce the risk that there's a chromosome abnormality in the pregnancy or a birth defect. And this test can be done by itself, but is often combined with some type of blood test for the mom. So those blood tests can include the combined screen, which would need to be the same day as that NT ultrasound, or the new non-invasive testing options that we have. And then in second trimester, we have the AFP or the quad screen. So currently with the combined screen, that's a combination of the NT ultrasound and a blood test. We detect about 90% of Down syndrome and 97% of trisomy 13 and 18. So this test by itself is pretty good at detecting those, and that's what many people are still choosing today. It's been around for quite some time, and people are very comfortable with this option. I'll talk about NIPT a little later, so I'm just going to skip over that for right now. In the second trimester, if someone has already had NIPT or the combined screen, we encourage them to do just maternal AFP to get some information on the risk of neural tube defects. And often if that comes back positive, then you're referring to a genetic counselor to have more discussion about options with that test. Because we do see, of course, on all these screening tests that there are false positives, so a high-risk result is not diagnostic. The quad screen we see here has about an 80% detection rate across the board. And so with this test, we don't really encourage patients to choose this test if they are coming in the first trimester. We'd encourage them to do a combined screen or NIPT. But if they're coming in the second trimester, this is one of their options, doing a quad screen, or now they have the option of NIPT as well for a higher detection rate. So one of the things that we get a lot is people wondering, well, oh, it's just this blood test, it's going to tell me that everything's fine with the pregnancy. And while that is the hope that we're telling you low risk, everything's looking great, people should be given that option of not doing any of this testing. Some people consider that I wouldn't change anything with my pregnancy, I might not want this information, I don't want to worry about it during the pregnancy, and making sure that they have the information about testing as well as the option not to test. The second trimester ultrasound is usually done around 20 weeks. Some people think of this as the gender ultrasound, finding out whether the baby's a girl or a boy. But we are very encouraging not to think of it as a gender ultrasound because that's not the main reason for doing this test. It does often can tell you that, but we can't give you just that information. They're also screening for other abnormalities in the pregnancy. And that if we're looking, we're going to tell you all of that information that we see. We can't be blind to that information. This test is, the second trimester ultrasound is actually much better at detecting neural tube defects than the AFP. So we've heard people, even if they had a normal AFP, that this ultrasound is actually a better test for neural tube defects. And then also a reminder that we can't detect everything with ultrasound. So a normal ultrasound, there still can be abnormalities with the baby. So this is not diagnostic again. As far as diagnostic tests go, there have been some updates with this. We're still offering people CVS or amniocentesis. CVS in the first trimester, or up to about 15 weeks, and then amniocentesis about after 16 weeks. Those numbers can vary a little bit depending on who's doing the procedure and just the individual pregnancy. As far as these go, we still have the option of getting the picture of the chromosomes, the karyotype. The new part of this is that some people are being offered a prenatal microarray. And this can give us a lot more information on pregnancy, can detect a lot more things. The disadvantage of this testing is that we don't always get an answer. If we find something abnormal on a microarray, at times we don't know what this information means. And so we like to really talk to people a lot before we offer these tests, making sure that they are comfortable with the possibility of getting an uncertain result. But it can be a good option for someone that knows that they have a family history of certain conditions. As far as that goes, if they have something in their family history, then an amniocentesis or a CVS gives us a lot more options for diagnosing known conditions in a family or ruling out known conditions. So now a little bit about the non-invasive prenatal testing. This test has been around for a couple of years. Is becoming more and more popular and being offered to a lot more women. So in the 80s, they discovered that they could detect fetal cells in mom's blood. However, these whole cells can circulate in the blood for a number of years, and therefore is not a reliable test for a current pregnancy because you could be testing a previous pregnancy. In the 1990s, they discovered cell-free DNA. So these are little pieces of the chromosomes that are free-floating in the bloodstream. Everybody has these as they're breaking down their cells. When you're pregnant, they say about 10% of those pieces are coming from the placenta. So we do know that this testing is essentially equivalent to the type of information we get from a CVS. So we're not testing baby cells directly, but testing placental cells. And this clears very quickly after delivery, and so therefore we are certain that we are testing DNA from the current pregnancy and not a previous pregnancy. So there's currently 4 main companies on the NIPT market. And there's 2 basic technologies that they're using. So I'll go through these 2 technologies, the counting method or the sequencing method. They all do it a little bit differently. They all have their own computer algorithms that they use to process this data, but 2 main methods. The counting method is used by Sequinome, Illumina, and Ariosa. The tests they offer are Harmony, Verify, and Maternity 21+. And then the sequencing method is used by Natera, which offers the test Panorama. So the counting method, which is the one that 3 of the 4 companies use, measures total free DNA. They're not separating mom from baby. And they again use different techniques of amplifying to get the DNA. They use different methods of analyzing the DNA, but they use the same basic method. So here's sort of a picture of how it works, is that they compare reference chromosomes to other chromosomes, and they get a normal result, or a trisomy where they're seeing more of a certain chromosome, or a monosomy where we're missing some of that genetic material. But again, we're not separating mom from baby, so they're actually, when they're looking at it, it looks more like this, where you're not actually telling that baby's one and mom's the other. But it's very accurate. Some of the companies have a positive result and negative result, or sort of this in-between aneuploidy suspected result. Other companies just report out the positive or the negative. And so that can be something to look at when you're deciding which test of the 4 to offer your patients, what sort of results you're most comfortable giving. And of course, all the companies are happy to talk to you. 2 of them are here. And so really getting more information on what might be best for your practice, or just deciding to refer to a genetic counselor. Failure rate is about 1% for all the labs. Those numbers, of course, vary slightly and are constantly changing. We try and stay up on the data, but those numbers change all the time. And false positive rates and detection rates, again, vary between chromosomes. Most accurate for usually Down syndrome, less accurate for the other conditions because they're less common. And these cannot detect triploidy, so having 3 sets of all the chromosomes cannot be detected with this method because the proportions look the same. And if there's a very small fetal fraction, so that 10% average is not true in everybody, if they have less fetal DNA than maternal DNA, then it makes the test less accurate. This test can be used for pregnancies from egg donors, surrogates, and also twin pregnancies. The sequencing method, which is the method that one lab uses, they sequence all the material, and then they use an analysis to decide which DNA pieces come from mom and which ones come from baby. And then they only look at baby's DNA to get the result. And adding paternal DNA sample can increase their accuracy in some of their cases. So they sort of divide out, use computer analysis to decide which DNA belongs to who. So again, they result in positive, negative, or that in-between result. They have a slightly higher failure rate. It can detect triploidy, so it can tell if there's 3 copies of all the chromosomes. But they cannot do pregnancies from egg donors or surrogates, and at this time they also are not taking twin pregnancies. And then, so as far as what disorders are tested for, this is again something that's constantly changing, something new. Traditionally, they were just looking for the risk of Down syndrome, trisomy 13, and trisomy 18, so very similar to the combined screen. They also look at the sex chromosomes, all 4 of the companies. So some people just want to know the gender. They do get that information as part of this, but again, is not the primary reason for doing this test. Yeah. I think, yeah, some of the companies have different pricing. It depends on who you order it through and all of that. Again, the pricing is constantly changing. Whether insurance is covering it is constantly changing. So that's really something to check in with the.
Some companies use sexy and some companies make it want to.
Yeah, sometimes it's an opt-in option. Sometimes it's an opt-out option if you don't want that information. So yeah, it can be different across the board. Did you have another question?
I was just going to comment about Panorama.
Yes.
And, their commitment to not bill the client directly more than $149 ever.
Yes, there are lots of deals, and it is really often changing. If insurance doesn't cover it, sometimes the companies can offer deals, lower cost. Sometimes they can offer them $0 out of pocket. Sometimes they can offer them a set low rate.
And I know that Natera's is $149.
That Natera, so currently Natera's $149 is what you're hearing. And we're often checking in with the companies, and they're often, have some sort of deal going on. Some of the companies can offer $0 unless they're contracted with the insurance company, in which case they have to honor those insurance contracts. The bigger thing that's being added currently is, again, these microdeletion syndromes. So these are very small missing or additional pieces of chromosomes. And so some of the companies are starting to be able to detect these. Some of the companies are offering trisomies 9, 16, or 22. And these, are often opt-in options, additional testing that you can add. These conditions are very low frequency in the population, so we're still getting a lot of information. They haven't done a lot of detection actually out in the population. They've done some studies to validate it, but they haven't been doing this for long enough or having a large enough population to get good big numbers that many people are comfortable. Some people order these tests, other people are saying, we're not ordering these tests right now, the false positive rate is too high. So here's some of the current data that I found. Again, these numbers are constantly changing, so it's important to check out that they're constantly making their tests better so that they have better detection rates. But as you can see, they're all fairly similar with their detection rates, detecting, for the most part, 99% of Down syndrome, 98% of trisomy 18, trisomy 13 tends to be a little lower, and their false positive rates are all very low, and the failure rate can vary, but it's mostly under 1%. Panorama, that failure rate there includes the redraw rate. Sometimes they'll redraw a test on somebody and get a result the second time, or they add in data flooding and can get a result, but that's not always possible. Yeah.
So by failure rate, you mean they're getting no?
The patient does not get a result. Sometimes it's due to low fetal fraction, so they say if you redraw it, then the fetal fraction may have gone up and they're able to get a result. Other times there's just something where they're just not able to get a result on that person. And so this is another reason that we often like to do maybe also an NT result, so that an NT ultrasound, so that that person has some information if they have a failure on this testing. So this is a screening test, so if we get someone back who has a positive result, we need to remember that this is not a diagnostic test. It could be a false positive. We should do follow-up testing to confirm that result. The current studies, those numbers are all in high-risk populations. There have been studies coming out saying that this test does work in low-risk populations, and it is being offered to low-risk women. Again, with the data that's coming out, those are for singleton pregnancies, so twin pregnancies, we know that it works, but we have less data on exactly how well it works. Insurance coverage is very uncertain. Some insurance companies cover it. Sometimes they'll cover it in some cases, not in other cases. It's really a case-by-case basis. The list prices, again, range from $795 to $2,700. But again, many of the companies are offering discounts. If insurance doesn't cover it, then they'll lower the rate, or they'll just offer a flat rate for people without insurance. And the turnaround time is about 2 weeks, oftentimes less, but oftentimes it does depend on where you are in location to the lab. There's a couple days shipping time in there, so consistently we're getting results back 2 weeks at the latest. And then the next thing I'm going to talk a little bit about is positive predictive value, which is really important in offering to high-risk women versus low-risk women. So this is a diagram of positive predictive value in high-risk women. So the prevalence of trisomy 21 in about a 40-year-old woman is about 1 in 100. And so with a detection rate of greater than 99%, we're going to assume that we're catching all of those cases of Down syndrome that are true cases. But over here on the right, with that false positive rate of 0.1%, there is going to say one false positive. So if we compare those to each other, 10 out of the 11 cases that came back positive to you and you told the woman you're high risk for Down syndrome were true positives. So that's a positive predictive value of 91%, which is very good. However, if we take the same test in a low-risk woman, saying that we're still detecting greater than 99%, and our false positive rate is still 0.1%, we only have one woman in that population who has a true positive. And she does get caught, so she gets her positive result back. And again, there's that one woman who was low risk, didn't have Down syndrome, and got that positive test result. And so now our positive predictive value is only 50% because one woman was a true positive, one woman was a false positive. So in the low-risk population, while our detection rates and our false positive rates are still the same, it's more likely that that positive result is a false positive. So that's something important to remember as we're talking to women about this test option, that it is a great test, but there is a possibility of false positive still. Much lower than other testing options like the combined screen, but it's still there. Are there any other questions on the non-invasive testing? I'm going to move on to carrier screening. Yes?
Are these companies limiting this test to women in a high-risk category?
The testing, no, the companies are not. The companies will run the test on whoever you send in. Insurance is more likely to cover it in high-risk population than a low-risk population, but still not consistent in either group. So carrier screening, as we're mostly talking about carrier screening for cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome. These are the ones that are for the most part being recommended by many of the larger societies like ACOG, ACMG. Cystic fibrosis and spinal muscular atrophy are recessive conditions. Fragile X is an excellent condition. And it's important to remember with carrier screening that, again, not all carriers will be detected. Higher detection rates in certain populations, but it is testing that we, for the most part, offer to everybody. So we know in recessive conditions that both mom and dad need to be carriers of the same condition for there to be a risk to the child. And cystic fibrosis, many people know about the condition, and this is something that is detected on newborn screening in Washington State. And here's some carrier rates in different ethnicities. Sit there. And then spinal muscular atrophy, the carrier frequency is about 2 to 3% in all populations. And this is a condition that is not detected on newborn screening. So if they don't do carrier screening in the pregnancy, this wouldn't be something that they would find out about until onset of symptoms. And then Fragile X syndrome is an excellent condition. So with a mom who's a carrier, there's a 50% risk of passing on her carrier status to a daughter or to a son. And it's a little more complicated because the mutation does have to expand for there to be symptoms in a child. So the risk is much lower than 50% in each pregnancy, but there is a risk with moms who are carriers. The carrier frequency is about 1 in 260. It's much higher if someone has some sort of family history of someone with an intellectual disability, with an autism spectrum disorder, a family member with fertility problems that have not been diagnosed, things like that. And again, not on newborn screening. The other one is hemoglobinopathy screening. These are higher in certain populations. Again, sickle cell in African American population, thalassemias in sort of the Mediterranean Asian populations. Often the first screen on these conditions is just an MCV, looking at those numbers. If those are normal, then the risk is much lower. And then there are certain other groups where we do, again, offer more carrier screening. The Ashkenazi Jewish ancestry has a number of conditions that they're higher risk for. French Canadian, Cajun or Acadian have a higher risk of Tay-Sachs disease. The Amish population has some conditions that they're higher risk for. So if someone is of one of these populations, then it's important to offer them additional screening for carrier status. And then again, if someone is a carrier, then we often offer their partner carrier screening as well to determine if there would be a risk to the pregnancy. And oftentimes these people do get sent to genetic counseling, and we offer them additional carrier screening for the partner, things with higher detection rates such as sequencing the gene instead of doing the same carrier panel, which might have a lower detection rate. And so as far as referring people to genetic counseling, we're happy to see everybody. We love talking to people about their options, making sure they have the information. We never make anyone test for anything that they're not interested in getting that information on. So if you have someone that you think might benefit, might have some sort of family history, we'd be happy to see them and know that we won't be forcing them to do any testing.
Question?
Yes.
You indicated autism in several of these comments.
Yes.
Is that now considered a risk factor?
So autism is considered, when we see someone with a family history of autism, for the most part, if they don't have someone doesn't have a genetic diagnosis, then we just talk about the fact that there could be increased risk, but for the most part, we can't give them specific testing. But we do know that it is a risk factor for Fragile X syndrome. It does increase the likelihood that they're a carrier of Fragile X syndrome. And thank you to Dana, who I adapted many of these slides from. And this is the contact information for the two counselors, myself and my coworker at Evergreen. We'd be happy to take anyone's referrals. There's also lots of other great genetic counselors in the Seattle area that are happy to see people. Thank you. Any other questions?